Hello, my name is Brian Baumann. I'm an assistant professor of radiation oncology at Washington University in St. Louis. And at this ASCO meeting, I presented the results of a comparative effectiveness research study comparing concurrent chemoradiotherapy delivered with either protons or X-ray or photon-based radiation therapy. Now, as of course this audience knows, concurrent chemoradiotherapy is a very common curative treatment approach for locally advanced cancers, but it is associated with substantial morbidity. And in the study, we wanted to see if the use of proton therapy, which allows radiation to be delivered to a finite depth toward the tumor target, and then have the radiation stop with minimal dose beyond the tumor target, if that might result in meaningful clinical outcome differences compared to photon radiation using X-rays, typically multiple beams all directed at the tumor with both entrance and exit dose, unlike protons, which really just has entrance dose. So to do this study, we looked at almost 1,500 patients treated from 2011 to 2016 at the University of Pennsylvania, all with curative intent with non-metastatic disease with either protons or photons. Our primary endpoint was rates of grade 3 and higher acute toxicities. These are CTCA grade 3 toxicities, which by definition are those toxicities so severe that they typically warrant an unplanned hospitalization. Secondary endpoints were rates of grade 2 toxicity, so those are the toxicities that significantly impair quality of life but don't usually lead to hospitalization. Decline in ECOG performance status during treatment, and then we looked at oncologic outcomes, disease-free survival, and overall survival. Our hypothesis was that protons would significantly reduce grade 3 toxicities without a reduction in cancer control outcomes. Now, of this patient database of almost 1,500 patients, 390 had received protons. Most of the patients were head and neck, followed by primary lung cancer, primary brain cancer, and GI cancer, with also some gynecologic cancer represented as well. I think the important thing about our data is that the data on the adverse events were all gathered prospectively using standardized forms with CTCA scoring at each weekly on-treatment patient visit and at all subsequent follow-ups. In addition, the oncologic data was also gathered prospectively. So while this is not a randomized trial, the quality of the data was quite good. We also built a very complete database that included clinical demographic and treatment-related factors, including detailed radiation treatment variables. And we used that to do a propensity score analysis using a machine learning ensemble approach, and we found that there was a statistically significant 2/3 reduction in the rates of grade 3 and higher toxicity in favor of protons. We also found statistically significant reductions in grade 2 toxicity and significantly less decline in ECOG performance status for those patients treated with protons. Disease-free survival and overall survival were not different between the two cohorts, and we did not expect to see a difference there, as these were patients treated by the same physicians using the same chemotherapy agents and doses and the same radiotherapy doses and fractionations. I think that this research points to a few future avenues for further exploration. One of those is that I think this points to the possibility of further intensifying chemoradiotherapy, in particular intensifying the systemic therapy if it can be delivered with protons, which might improve oncologic outcomes. It also points to the possibility for broadening inclusion criteria on future chemo-RT trials that involve protons to include older, sicker patients, because our proton cohort was actually 5 years older on average and had significantly worse baseline comorbidities than our photon cohort, and that is just a byproduct of insurance approval in the U.S. with 65 and older patients on Medicare having protons covered, while most younger patients with private insurance not having access to protons because it is not covered. So future research will also look cost effectiveness. So on the comparative effectiveness standpoint, we think protons is looking very good. The question is whether protons, with those reductions in serious toxicities leading to hospitalizations, might be able to pay for itself, because it is a more expensive therapy. And those questions remain unanswered. But I hope that this study will spur future research in this area, and that more trials comparing proton versus photon chemoradiotherapy can be opened and accrued to. Thank you for the opportunity to talk about my research.